Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Commonwealth Fund, on measuring social determinants of health among low-income populations, early insights from state initiatives. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on CHCS.org. At the end of the webinar, we ask that you complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I'll now turn the webinar over to Tricia McGinnis, Vice President at the Center for Healthcare Strategies.
Thanks, and welcome everybody to today's webinar on measuring the social determinants of health among low-income populations, early insights from state initiatives. My name is Tricia McGinnis, and I'm Vice President of Programs here at the Center for Healthcare Strategies. We are excited that you've joined us for today's webinar, where we'll share information on current Medicaid agency efforts to collect social determinants of health data. First, I want to thank the Commonwealth Fund for supporting this webinar and the related issue brief that CHCS published last week on this important topic. I'm joined today by Anna Spencer, Senior Program Officer here at the Center for Healthcare Strategies, Pamela Riley, Assistant Vice President of Delivery System Reform at the Commonwealth Fund, Arlene Ash, Professor of Biostatistics and Health Services Research at the University of Massachusetts Medical School, and Sarah Bartleman, Metrics Manager at the Oregon Health Authority. Over the next hour and a half, we'll share findings from our research on how states are moving ahead with standardized social determinants of health data collection. First, we'll hear from the Commonwealth Fund about work that they are supporting around social determinants of health and how this fits into their strategic priorities. Then my colleague Anna Spencer will give an overview of the findings from our research on what states are collecting and how they are using social determinants of health data. Sarah Bartleman will talk about Oregon's efforts related to developing social determinants of health measures as part of their coordinated care organizations. And then Arlene Ash will share information about her work with MassHealth to incorporate social determinants of health data into rate-setting models for accountable care organizations and managed care organizations. Finally, we'll leave plenty of time for questions and answers for the audience, which you can submit via the question function. Briefly, for those of you who may not be familiar with the Center for Healthcare Strategies, we are a nonprofit organization that works with Medicaid agencies, Medicaid health plans, Medicaid providers, and the Centers for Medicare and Medicaid Services to improve the health of low-income Americans. And we do so under three key priority areas. First is supporting broad-based state efforts to transform how care is paid for and delivered to consumers. Second is integrating services for people who have complex needs. And the third is in advancing access to health care coverage and services. We provide technical assistance, disseminate emerging early lessons and best practices, support Medicaid leadership capacity development, and support peer-to-peer learning opportunities that are so critical for cutting-edge issues. Needless to say, the topic of the social determinants of health is critical to all of our work here at CHCS. This specific project on social determinants of health measurement builds on other work that we have done with the Commonwealth Fund and other funders, including the examination of potential funding models that states can use to support this work on the ground, as well as case studies of different approaches that Medicaid agencies have taken programmatically to encourage providers to incorporate social determinants of health strategies into care delivery. We have done extensive work on this issue through our Medicaid ACO Learning Collaborative and have worked with several organizations to explore approaches to housing in particular, given the evidence base around how housing can really drive improved health and lower costs. And with that, I'll now turn it over to Pamela Riley at the Commonwealth Fund to share how her organization is thinking about and approaching these issues. Pamela?
Thank you, Tricia. And so I'll just give an overview of how the Commonwealth Fund is approaching integration of healthcare and non-medical services. And the Commonwealth Fund, we're a private foundation focused on creating a high-performance health system, and we do so primarily by funding policy, research, and convening relevant stakeholders around particular issues. Next slide, please. As a bit of context, our work in this area is centered in our delivery system reform program, which really aims to create high-performance health systems for two populations: high-need, high-cost patients and vulnerable patients, primarily low-income populations. And we do so by trying to understand what are the needs of these two populations, from there identifying the best models of care to meet those particular needs, and then finally investigating policy and payment strategies that can support the spread and scale of effective care models for these groups. Next slide, please. So why have social needs gained such prominence in the last few years, even though it's not a new issue, and there certainly have been healthcare providers that have been focused on this for a long time, but it really has gained some traction for a couple of large reasons. Number one, the Affordable Care Act, with the coverage expansions through the Affordable Care Act, really brought millions more low-income, vulnerable patients with social needs into the healthcare system, which created more of a demand for being able to meet these types of needs in the context of healthcare delivery. And secondly, alternative payment models have really helped to drive a greater sense of accountability for outcomes that healthcare alone cannot address. So we've seen, I think as a result of both of these pressures, we've seen a lot of innovation among healthcare providers and payers who are really actively trying to explore ways to integrate addressing social services as a means of achieving better quality, better costs, improved outcomes for their entire patient populations. Next slide, please. The Commonwealth Fund's approach to this has really centered on what can and should be the role of the healthcare system in addressing the non-medical needs of patients. So we've really tried to capitalize on where the opportunity is here, namely with risk-bearing organizations that are being held accountable for improving the quality and efficiency and outcomes of their care delivery, organizations that will have some incentive to look at some of these non-medical factors and try to incorporate some of these services. So how do we maximize the opportunity of the move towards value-based payment to really drive the integration of these services? And how do we identify which services and which needs are really going to contribute to benefits to the healthcare system sort of in the near term that would align with the interests of payers? So it's a little bit more limited, but it's trying to really capitalize on the incentives that the healthcare system might have at this point to focus on identifying patient social needs and integrating services that meet those needs. Next slide, please. Just a few examples of our approach to this. We start in the upper left here with trying to identify what the needs are, and we're aware that there are a lot of gaps in knowledge about what are the social or non-medical needs of low-income populations. So to that end, we're conducting some data analyses to better understand the relationship between healthcare utilization and spending with some non-medical needs or material hardships such as housing hardships, food security, transportation challenges, those sorts of issues, to get an idea of, number one, of the prevalence of these, but also to the association between non-medical needs and poor care and poor health outcomes, but also to get to a place where we can say what is the impact of addressing these non-medical needs to improving health care and health outcomes. And along those lines, we really would like to make the value case for investing in these services. How can we demonstrate that addressing patients' social needs improves quality, can potentially reduce costs, improves outcomes, and improves population health? On the right side, we focus on promising models to address patients' healthcare needs and how do we facilitate the healthcare system being able to address patients' needs as appropriate and in an efficient way. So we are focused on how do we, for example, create tools or models for connecting patients with community-based resources. And I would just note that an important part of helping health systems and providers and payers being able to address these needs is the quality measurement piece. The ability to measure social needs and to measure progress on that, to measure whether or not they're being addressed and the contribution of that to improving health outcomes is really key. And I think that's a lot of where the work that you're going to hear about today is so important. And finally, on the payment and policy side, we focused largely on Medicaid as a potential driver of improvements in this space, primarily because the Medicaid population is highly vulnerable and does have a lot of social needs that Medicaid as a payer has somewhat more motivation to be able to address these things. So we're looking at, for example, what managed care organizations are doing in this space to really drive integration of healthcare and non-medical services, or what Medicaid accountable care organizations are doing. So we hope to continue to do more work in this space looking at Medicaid as a driver. Next slide. So that basically summarizes the Commonwealth Fund's approach, and I will turn it back over to Tricia.
Thanks, Pam. Before I hand this off to Anna Spencer to talk more about the findings from our research, I just want to first acknowledge, as Pam did, that, at the end of the day, most of the hard work around addressing social determinants of low-income populations is really happening on the ground. It's happening at the community and provider levels, among partnerships that are forming between community-based organizations and social service agencies, alongside healthcare providers, and including community-based healthcare providers. And in many ways, healthcare policymakers, payers, and even providers are relatively late in the game to tackling important issues that CBOs and social service organizations have been working on for years to address. So I just want to first acknowledge that. But I also want to say that we think that Medicaid agencies can play a really important role in supporting these efforts more effectively, not only by creating new payment models under which these approaches can thrive, but also by facilitating standardization on how we measure this activity to make it easier for folks on the ground, but also for researchers looking to evaluate the effectiveness of these approaches and to build the evidence base that is so critical. And on that note, I will hand it off to my colleague, Anna Spencer, Senior Program Officer here at CHCS, to share more information about what states are doing around social determinants of health measurement. Anna?
Thanks, Tricia. Let's start with the next slide. Okay, so I'm just going to start with an overview of our recent work scanning state activity around the collection and use of SDOH information. And all this information is captured, as Tricia mentioned, in our companion brief that was released last week and is available on the CHCS website. But to Pam's point, there's growing appreciation that non-clinical factors have a significant impact on health outcomes and health spending among Medicaid beneficiaries. And as reimbursement moves from volume to value-based and total cost of care models, states, health plans, and providers who are increasingly being held accountable for patient outcomes are developing strategies and programs to address social determinants of health. And given the characteristics of the Medicaid population, they are significantly more likely to experience social challenges like housing and food insecurity, transportation difficulties, and low rates of literacy, for example. State Medicaid programs are in a unique position to identify and address these social determinants in order to improve health outcomes and hopefully lower health care costs. But in order for state Medicaid programs to adequately and effectively address the non-clinical factors that affect Medicaid beneficiaries, states need a standardized approach to SDOH data collection, as well as a standardized approach to using this information. And Medicaid can play an important role to drive consistency on both fronts. Slide. So our project overview, the aim was really to understand what key SDOH data states are collecting, how are they collecting the information, and in what ways are they using this SDOH information to inform care delivery, make program improvements, or for informing other bodies of work such as risk adjustment and rate setting. We conducted an environmental scan of several states to collect information on the activities they were engaged in under SDOH measures. We started with a sample of states and programs that we knew were collecting this type of information, but also talked with staff from the Centers for Medicare and Medicaid Innovation about the Accountable Health Communities model, which is designed to address social needs in specific regions by enhancing clinical and community linkages. We also talked to the Association of Community Health Plans and an MCO in Ohio, CareSource, which has developed a program for connecting enrollees with sustainable educational and employment opportunities. We interviewed key staff from Medicaid programs and some public health departments. We spoke with metric managers, key researchers in the field, as well as experts in health information technology. And our primary questions to our informants were, what SDOH domains are states interested in, and how are they collecting this information? What is the process for selecting specific measures? In what ways are states using patient and population SDOH data? And what challenges are states facing in capturing this kind of information? So here's just an overview of the common SDOH domains are collecting from beneficiaries at either the patient level or the population level. This is certainly not a comprehensive list of all the SDOH domains, and states aren't necessarily collecting this information across their entire population, but these specific determinants were frequently cited by states that we interviewed. And there's an important distinction here. Patient-level SDOH data is being collected often, but not always, by assessment tools, and is being used for targeted patient-level interventions. While state agencies, and this includes public health, housing, substance use agencies, are also collecting SDOH information at the population level using existing data sources such as vital records or information from school-based health centers or behavioral health agencies, and evaluating social determinants across a broad population. But the most common domains we came across were, and I'll list these for you, housing, family and social support, education and or literacy, food security, employment, transportation, involvement with the criminal justice system, and intimate partner violence. So the major findings from our scan is that really states are in the very early stages of collecting SDOH information for Medicaid beneficiaries using standardized measures and a standardized approach. And this is due, we think, to a number of factors. First, we found while there is agreement among states on the main buckets that fall under SDOH, or the domains that we shared, for example, on the previous slide, such as housing and food security, there is not necessarily agreement on other domains, such as behavioral health or tobacco use. There's also lack of agreement on the elements that make up those domains, or the degree of social need that constitutes sort of housing insecurity or food insecurity. There's quite a bit of variability in terms of those definitions. There's also an absence of standardized measures that have been developed at the national level, and as a result, states are using homegrown tools and measures. And this variability makes it difficult for states to aggregate and compare across populations and over time to assess change or improvements. So by and large, states are in the very early stages of identifying their own priorities. Let's back up one, just a minute, thanks. Just to the last couple bullets, states are in the early stages of identifying priorities and associated measures, but what we found is that states are often starting small with a handful of SDOH domains and often collecting this information from a subpopulation. Okay, so we found that states are using SDOH information for 4 main purposes, and these include patient care management, incentive and performance programs, for elements in risk adjustment and rate setting methodologies, and for use in surveillance and program quality improvements. Next slide. So the first category, patient care management, this is at the patient level, and it's often used to guide care management. It was the most common use of SDOH we found, and it really offers a starting point for states interested in understanding the social needs of Medicaid beneficiaries. States are collecting information using intake forms, often at eligibility determination or as well as during routine assessments with beneficiaries. It's often done by care managers or community health workers, and is being used to connect beneficiaries with community service and social supports as needed. An example is Vermont's SASH program, which connects seniors and individuals with disabilities with supportive housing. And care managers are collecting information on a range of SDOH, including social isolation and food security, during routine assessments with the SASH enrollees, and then are using this information to connect the enrollees to services that are available within their communities. States are also using SDOH information in developing their incentive and performance programs. We found that some states are aggregating patient-level SDOH data for MCO performance accountability. And an excellent example of this is Kansas, through their CanCare contract with MCOs, have included a number of SDOH domains in both basic performance measures and into their pay-for-performance measures. And just up on the slide, there are a couple of examples, but what I will say about these are they're just a handful of examples from a very robust set of measures that CanCare has developed, and these were pulled directly from the contract. But the basic performance measures include % of beneficiaries who report being connected to social supports, or the % of beneficiaries who report doing what they want to work. Examples of pay-for-performance measures include the % and number of beneficiaries with substance use disorder whose employment increased, and these are the state looks at beneficiaries within a certain region and over a certain period of time, and similarly the % and number of beneficiaries whose criminal involvement with the criminal justice system improved, again within a certain region over a certain period of time. But the contract lays out very clearly what the specifications are for each measure and the frequency of collection. In Oregon, their performance improvement project, they're developing a food security measure, which Sarah will talk about in just a couple of minutes. But the intent is to help CCOs with their population health management and to help providers address obesity and functional impairments, among other things, among the CCO enrollees. Next slide. A few states we interviewed are using SDOH information in their risk adjustment methodology and rate setting calculations. For example, the New York Medicaid Health Homes Program, which serves beneficiaries with chronic conditions and or serious mental illness, use a functional assessment questionnaire. It's called the HML, or High, Medium, Low Functional Assessment Questionnaire, that asks beneficiaries about their experience with incarceration, homelessness, and interpersonal violence to determine provider reimbursement rates based on patient acuity level. Additionally, in the coming year, MassHealth, which is the Massachusetts Medicaid program, is planning to use risk adjusters to capture homelessness, substance use disorder, and a neighborhood stress score in their provider rate setting methodology. And Arlene Ash is going to speak to that towards the end of our presentation. In terms of surveillance and program quality improvement at both the population level and patient level, Medicaid and other state programs are using SDOH information for both these purposes. For example, the Massachusetts Department of Health uses information from over 300 data sources and 40 SDOH domains to evaluate population health indicators, how social factors affect certain communities or subpopulations, whether programmatic changes are having an impact on populations of interest, as well as how these social factors relate to one another. So just sort of as an example, that initial slide that pointed out sort of the main or most common buckets we found, and I think there were sort of 7 or 8 of them, you know, Massachusetts has identified over 40 SDOH domains that they consider as sort of falling under the rubric of social determinants. Similarly, the Vermont Department of Public Health uses a social vulnerability index, which is a population-level surveillance tool designed to identify the relative social vulnerability of populations across the state. It's often used in emergencies or after disasters, but is also used by the state to identify populations in greater need of assistance and support. And the tool uses 16 measures of vulnerability across 3 SDOH domains to track the prevalence of poverty, income, education, and insurance status. And program quality and improvement and evaluation, the Michigan Pathways for Better Health program, which is another targeted level program that addresses the need of beneficiaries and links them to preventive health services, uses aggregated patient-level SDOH data for program evaluation and to better understand the social needs and resources of the communities in which it's operating. So challenges to collecting, using, and sharing SDOH data. What we heard throughout our scan is that the lack of standardized measures at the national level means that states, plans, and providers are using a wide range of sources and tools to assess the social determinants of health. And this variability in measures and specifications makes it challenging to aggregate data across populations, within states, and more broadly as well. There are technical challenges associated with collecting and using SDOH information, specifically around extracting SDOH information from EHR for use by providers and social service organizations. Interviewees cited administrative barriers, which include extra burden on providers to both collect the information, but also have the capacity and resources to use it in an efficient way. Data sharing and privacy issues of this information, so sharing across providers, particularly social service providers who are often not linked to an EHR, poses a challenge. And then identifying an adequate source of funding, both at the state level and provider and plan level, to support SDOH measures collections efforts. Next. So just finally, from our perspective, this slide captures some key considerations that states might want to think about as they embark on measurement development and SDOH collections efforts. And the first really is to develop a strategy or framework to help guide work in this area. So first, states want to identify clear goals for SDOH collection. What are you interested in learning more about, and how do you plan to use this information? And the answers to these questions will really guide measure selection. States need to identify which SDOH domains they're interested in collecting and develop a common understanding across plans and providers about the elements that fall under that, or the definition, the elements that fall under the domain. States want to be specific in their measure development or decide which tool to be used to collect SDOH information, and also develop guiding principles for reporting on SDOH information and how this work will be financed. As states consider collecting information on SDOH, it seems a good place to start is to use existing structures to deploy and monitor SDOH collection. These can include MCO contracts and already existing quality measurement efforts. It's important to involve key stakeholders early on in both the measures development and testing process, and this helps to formulate a clear understanding and rationale and process for implementation across all relevant stakeholders. And in instances where data is already being collected, either at the patient or population level, states can play a role in encouraging the exchange of already existing information. And finally, states can introduce and test payment models that provide incentives to providers to address the social determinants of health. And with that, I will turn it over to Sarah Bartleman.
Great, thanks. So I think everything Anna just covered is absolutely true for our Oregon experience, and I'm going to share a little bit about our experience this past year developing a social determinant of health measure, specifically food insecurity, and that was something we were looking at for our Medicaid health plans or coordinated care organizations, CCOs, as part of our pay for performance program. That's not quite where we landed, but that's where we started, so I'm going to talk through our process. Next slide. So just a little bit of background on Oregon's coordinated care model. This is part of our health system transformation efforts as part of our 1115 demonstration waiver that we started in 2012. We moved about 90% of our Medicaid enrollees from a managed care structure into our coordinated care structure, where we have a single contract with an organization to provide physical, dental, and mental health under a single contract on a global budget. And these are some of the key principles of our model. And I really like to start here because for maybe the first time in our state, we really highlighted both measuring performance and transparency in price and quality. And so that combination here related to social determinants of health measures where we want to move towards paying for outcomes in health, and some of our strategies to get there are going to be that measurement and transparency. Next slide. And to set the stage, we have 16 coordinated care organizations across our state. Only a handful of them overlap. We have a couple of geographic regions with overlapping care. Otherwise, service areas are distinct. And we have just over 1 million Medicaid members in Oregon. Next slide. Another piece of our 1115 waiver that we stood up in 2012 was a pay-for-performance program for the coordinated care organizations. This is our incentive measure program. And it is an annual assessment of the health plan performance. We currently have 18 measures. Those measures are selected by our legislatively established committee that reviews all of the measures on the data annually and makes any updates or adjustments. And we look at comparing annual performance against the prior year to see if our CCOs have either met an established benchmark, a statewide benchmark, or if they've demonstrated a certain amount of improvement year over year. And if they either meet the benchmark or that demonstrated improvement, they're eligible to earn incentive payments. And for calendar year 2016, it's actually 4.25% of their annual capitation payments are at risk. That works out to about $180-some million for the year that we're expecting to pay out based on those 18 measures. So as you might expect, anything that becomes an incentive measure gets an incredible amount of attention and focus. Nobody wants to leave any of that money on the table, and so it's an incredible tool for focusing quality improvement efforts and performance improvement across the state. But on the other hand, we really rapidly run into things like measurement fatigue and are we measuring the right things, and not everything that people want an incentive measure can be an incentive measure. So our program has been evolving a little bit since we started. Next slide. And you can see here that our initial measure set was very traditional. In about 2012 and 2013, we started with your standard HEDIS quality measures. They're very process and access focused, so adolescent well care visits, colorectal cancer screening, emergency department utilization. And while we've been seeing all of those moving in the right direction, that's not really our full intent, and we don't think that that's necessarily going to get us to better outcomes and the triple aim overall. So more recently, in 2015 and 16, we started adding more population health-focused measures. So we're now paying for performance on childhood immunizations, effective contraceptive use, and tobacco prevalence. So tobacco prevalence it could be in both population health or outcomes measures column here, depending on how you look at it, because it's not related to screening or cessation services offered. We are actually holding the health plans accountable for the actual prevalence in their population. And then we're looking for year-over-year improvement. So that's pretty aggressive, but again, a step in that direction. We also have a really strong desire to move to outcomes-based measurement and social determinants of health measures for the incentive measurement program in the future, and not just for this program, but for other state efforts and initiatives. But turns out it's pretty challenging to collect this data at the individual level and at the health plan level in some cases, and in a timely fashion. So we've experienced this a little bit with our tobacco prevalence measure, but it's certainly true for some of these other social determinants of health measures where we have a program where we're looking for annual improvement, and as we move more and more into outcomes and social determinants of health, we're looking at change that takes place over multiple years, and certainly if we're talking about things like adverse childhood experiences or ACEs, we're looking at adult outcomes for experiences that happened in childhood, and so quite a lengthy period of time that we're looking to influence over, and that factors into implementation. So next slide. As part of our incentive measure program and to help inform our committee as they review the measures each year and think about what to add or drop, we fielded a couple of stakeholder surveys, and these went out really broadly in the state, so to the health plans, to providers, to stakeholders, to community organizations. And this most recent survey, we asked a couple of open-ended questions because we wanted to get some sense of direction to help inform discussion and to help identify new measures or where measure development might be needed. And that question was, what would tell you that health system transformation in Oregon was successful? And then the corollary question, how should we measure that? And this pull quote from the survey really summarizes a lot of the intent and direction that we're hearing and where we want to go. And I think it's very clear that we want to look outside of maybe the traditional healthcare system and beginning to address some of the real factors that influence people's health and their lives. So looking at health status, looking at housing, employment, mortality, incarceration, kindergarten readiness, which would look at some coordination between the health system and education and early learning, as well as the built environment, and then in particular food insecurity. So based on that stakeholder survey and based on quite a bit of public testimony and other input from some advocates, our committee decided that they were interested in developing a food insecurity measure. Next slide. So talking a little bit about that process, we really first started with getting that committee buy-in, and some of that came from the stakeholder survey, and others came from presentations and public testimony. All of our committee meetings are public, and anyone can come and submit public testimony at any point, and so we had this come up. So some of our key advocates and stakeholders listed here had come forward, and they really made the case to the committee about the connection between hunger and health and provided a lot of that foundational education on why we would even be talking about food insecurity for the Medicaid program. We got the committee bought in. They decided that this was a good addition potentially to the incentive measure program, and they referred it to our technical work group. So we have a group where all of our health plans can participate, as well as some more data-focused folks, and we work through measure development or specification issues. And so once we got to that technical work group, we realized pretty quickly that there were no existing measures that did what we need them to do. Certainly there was data on food insecurity for Oregon at the population level, but for a measure to work in our pay-for-performance program, we had to have something that was stratifiable at the health plan level, and we didn't currently have any mechanisms for that. So we also realized not only was there not an existing measure, it wasn't just about technically developing the specifications, but also we had a lot of conceptual development that we had to do as a community. So when we're talking about food insecurity, what are we really looking for? What do we really mean? And I'll talk about that in a second. We also spent a lot of time on education with our technical group. So some of the same presentations that went to the committee about that connection between hunger and health, but then also hearing from peers what are health plans in Oregon already doing, what are providers already doing. We have some really innovative projects in this area, and it wasn't necessarily well known. We have veggie prescription programs, we have mobile market programs, we have one program at one health system focusing on screening and intervening. So a whole health system was already screening their patients for food insecurity, and then they had community navigators sitting at desks in those primary care offices that could then help connect patients with community resources like the food bank. So we wanted to really surface that, and so some of our health plans said, why are we even talking about this? This isn't our responsibility. But we had some other health plans who said, actually, we think this is really important, and here's what we're already doing in this area. We continued our conversations around technical development. We talked about, what is the data source for this measure? Where should it come from? What are the specifications? Who should be included and excluded? And a whole bunch of challenges there. And then finally, when we got to the point where we thought we had a viable measure, it was time to move it into testing. Next slide. So talking a little bit more about that conceptual development, when we're talking about food insecurity, we had a lot of buy-in for the concept, but we didn't necessarily have a good sense of the scope of what we wanted to measure. So we surveyed our technical work group. The N here is 16 for our 16 health plans, and we asked, in an ideal world, a food insecurity measure would include, and we had a list of options and some open-ended responses. And we asked them to differentiate their response between, in an ideal world, if we had all the data we needed and if we could measure this, with no added burden, however we wanted, and then reality. So if we were going to measure this next year, what would we include? And what I want to note here is that even though the goal of this measure would be to move to a social determinants of health measure, and even if with that focus on outcomes, our instinct as a measurement community was to focus on the process, the things that we could check off. So did the food insecurity screening occur? That's a yes-no checkbox in an EHR. That's something that our health plans and providers felt that that's pretty firmly in their control. And then as you move to the right on this slide, you can see that we have less and less support for some of the more qualitative pieces. So what type of follow-up was provided? What were the outcomes of the follow-up? Next slide. And so then some of our conceptual and technical considerations that we've been working through. So on the conceptual side, we had to start off with, are we measuring this at the providers, essentially the patient panel population, or are we measuring the health plan, all of the Medicaid enrollees of that coordinated care organization? And that really makes a difference, not just in where our possible data sources might be and how we might collect the information, but also in terms of intent. If we're talking about collecting the information at the provider level, it needs to be individual, it needs to be actionable, the provider needs to feel like there is something for them to do, and that might be a different focus and a different type of intervention than what we might expect the health plan to do. Like on the previous slide, are we measuring the screening or the results of the screening, or somewhere in between, or both, some kind of composite measure? Are we talking about food insecurity or food insecurity and malnutrition? And this actually turned into a pretty hot topic with some of our registered dietitian community, and we ultimately landed on just food insecurity. But again, it was a really interesting conversation thinking about all the ways that malnutrition affects health, and including some of our other measures that are already in our program. We also talked a lot about community resource availability. So particularly from a provider level, are we asking providers to collect this data if they weren't already? And then if there's no resource, if there's nowhere in their communities that they can refer a patient to for help or support, is that ethical? We had a lot of conversation about whose responsibility it would be to institute those kinds of resources. So we wanted to be really careful about moving forward with a measure until we had thought through what the implications actually would be of having a measure in the field, because we knew that once incentive dollars were tied to it, everybody would be jumping to screen or to do whatever process the measure called for, but we maybe didn't necessarily have the community system fully resourced to support that. On the technical side, do we want the measure to be survey-based, claims-based, data from EHRs? We heard loud and clear that for this kind of measure and to move into this arena, we really needed the data to be actionable. So that ruled out survey data for an incentive measure. We don't really want to survey just a random sample of each health plan because we wouldn't necessarily then be able to connect any of them with resources. We'd get a good sense of the prevalence of food insecurity in the population, but wouldn't necessarily actually help anybody do anything about that. We also talked about whether this should be focused on adults, children, the whole family. How do we link children and their parents or their caregivers in our data? How do we do that for measurement? Who should be excluded? And then standardized screening tools. And this was a big conversation that we had because there's not a sort of off-the-shelf, this is the ultimate screening tool. There are certainly lots of opinions about what the best screening tool should be, and there's some standards. USDA has some pretty standard questions that can be used, but they weren't necessarily designed as the single screening tool that was standardized for a measurement, and so we had a lot of discussion about that. Next slide. So where we've landed, as of July, we thought we had a viable measure. We had specifications worked out, and they're linked in an earlier slide. And where we landed was that we really needed this to have some testing in the field. Custom electronic health record-based measures are complicated. They take a lot of time to build out in an electronic health record and to make sure that you're getting data and everything is linked up with workflows and the workflows are populating the right fields that you then need to pull for measurement, and that we weren't ready to pay for performance on this, and that we needed some time for testing, and this needed to be moved into the field for potentially some additional refinement. So we recommended that this measure move forward as an optional performance improvement project measure. So under Medicaid managed care, all of our plans have to have a certain number of performance improvement projects focused in various areas, and this would fit well into that for optional selection. And because we were talking about a measure that would be used in the incentive program in the future, we probably overcomplicated things. If we were just talking about measuring social determinants of health or measuring food insecurity for Medicaid in general, there were a lot of other options that we could have pursued, but because we wanted this specific actionable data stratified at minimum at the health plan level, if not also at the provider level, it really influenced our path, and I think that's what led us to need this additional testing to make sure that we got it right. So our health plans are continuing to do some of this testing to explore some different approaches. Many of them are thinking about ways that they can collect this data locally. We have several health plans that are pursuing essentially a combined social determinants of health screening tool that would include this as well as a number of other social determinants. One of our health plans actually conducted a community-based survey a little bit ago. The graph displayed here is from their survey, and this is not limited to Medicaid. They surveyed their whole community and focused in on food insecurity as being a particular problem for their region, and that led to essentially some bringing together of some local businesses and the development of some fruit and vegetable promotion programs that they're hoping will be able to address this. Next slide. So just a couple more notes here. As we are moving into this area, well, one thing that we realized was that it's not just about the technical details or the data source issues. So obviously when we surveyed, it is about building food insecurity screening into an EHR and all the technical considerations, but also all of the other contextual issues in terms of how to talk or how to even address this at both the provider and the health plan level. Next slide. And as I mentioned, we do have a couple of other things that we're pursuing. So we are looking at collecting some data from surveys. We're looking at an integrated client services data warehouse that will be able to match Medicaid data with data from other social service agencies. We're exploring the use of some new ICD-10 codes for socioeconomic and psychosocial circumstances. Some really interesting opportunities there, but also probably pretty challenging to implement. And then we've also had some conceptual conversations of some kind of annual health risk assessment that would happen upon Medicaid enrollment. And we see all of these as potential paths to keep exploring to collect this kind of data. And final slide, we have a lot of information on our website, so please feel free to take a look and contact us if you have any more questions. Thanks.
Thanks very much, Sarah. That was great. So now we'll turn it over to Arlene Ash, who is going to talk about the Mass Health Risk Adjustment Model. Away to you, Arlene.
Thank you. Thank you. Okay. So I guess you're on the slide. First slide. How about next? So just a moment to introduce myself. I'm a mathematician who wandered into healthcare many decades ago, or several decades ago, and I was involved in the work that built the models that CMS uses for risk adjustment in the Medicare Advantage program. And so a large part of my work in this area over decades has been to think about how to put enough stuff into the model, the payment model, and the right stuff into the payment model so that managed care organizations or contracting entities that agree to take care of populations will get enough more money to deal with really sick people so that will be a viable business model. So over the many years, that sort of has become a real specialty and passion of mine. Some of that work, that first phase of work was effectively completed and just has modest updates as early as the late 1990s. This is a new venture to say we've done a really good job of creating a rolled-up score which looks at the age and sex and the medical problems present that we can infer from diagnosis codes on claims to predict how much somebody's going to cost in a program. And I think, you know, those models are very mature. People make small changes, but they're not really going to substantially get improved in the near future. This project for the state has given us the opportunity to ask what information beyond age, sex, and a medical profile derived from ICD codes can we use to try to make fairer payments. And in particular, there's a practically universal agreement among everybody I've ever spoken to in the state that to the extent we are able to capture social determinants of health in these models, that is desired. Okay, so next slide. So I'm going to talk about the part of this project which actually has produced a model that is being used to pay managed care organizations, and that started earlier this fall. So we have a version 1.0 that is moving money around in the state of Massachusetts Medicaid program right now. Our current work is based on updating those models with newer, we can go to the next slide. Updating those models with newer data, more recent data, and also trying to see if we can squeeze more information out of existing databases so that we can improve the models. The concept is to try to have your outcome that you're looking for is total cost of care, and we didn't quite go there yet. The total cost of care variable that we have is we removed long-term support services. I'll talk about why, and I'll talk about why our strong goal is to try to put that back in on the next round of research. But basically, we have, as I say, a good medical model to start from. It's highly predictive. You get R-squareds in the concurrent setting of over 50%. These models really do make dramatically different predictions for people who are very sick versus people who are fundamentally healthy. But our goal was to augment those models with existing data, not to go imagining what we might do if we had better data on everybody, but to find data where the variable could be defined at the person level for every single person in the Medicaid program, and that could be used to modify the payments to MCOs. Next slide. So even though the underlying DXCG score actually contained HSEX categories, we have found that it's a useful thing to take the rolled up score and add HSEX categories on top of that, and it helps to tune the medical model to differences in how money is spent across people of different age and sex in your state. And we actually found that that was important, that about half the people in the state Medicaid program are kids under the age of 18, and that there was a systematic underpayment, which we were able to fix by throwing that in. We kept searching for all the things that were in the administrative files, what kinds of information were present that we could use, and we said nobody's actually used, in this existing model, nobody is using the information about disability status. And we found that we could make pretty sharp distinctions and improve the accuracy of our model by recognizing the simple fact that some people are entitled to the Medicaid benefit through disability, and even more to the point that the subgroup of people who are clients of the Department of Mental Health or the Department of Developmental Services had additional costs associated with that. So we created a four-tiered variable, which is client of the Department of Mental Health, the Department of Developmental Services, if not mental health, simply disabled if neither of the above two, and not disabled at all. And we found that that actually was important. We also found that although the diagnoses that contribute to serious mental illness or substance use disorders are incorporated in this rolled up medical morbidity DXCG score, we found that simply having markers for clusters of medical problems that were recognized by ICD code in these categories of serious mental illness or substance use disorders, that they actually were important. So then we were searching and searching, what could we actually do with social determinants of health variables that, as you can see, up till now, I haven't really touched on very much. So we had a homelessness variable in the administrative databases, and it was useless. We found that the people for whom it was marked didn't appear to be different from anybody else. people who were close to the data collection told us that it wasn't a very reliable variable. Empirically, it didn't look like a very reliable variable, and so we were pretty unhappy about that. But then we said, what can we find that will help us capture issues with housing? And we were able to come up with 2 variables related to housing that I'll talk about. Next slide. Okay, so we're holding off on how we captured housing, but just to talk briefly about how we did the modeling. And we do have a model that is being implemented now, and its predictors include the kinds of information that I've talked to you about. And I think it's very important for people to understand that the goal of our research is to produce a relative risk score, an RRS, a relative risk score, that is based on all the data that we can aggregate about a person's risk factors for being expensive within the Medicaid healthcare system. And let me say that we want this relative risk score to be, we made this relative risk score be closely linked to what the payment bundle would be. As I said, long-term supportive services are not in the current payment bundle. We wanted that. We think it's important that it be there, but it isn't yet. And we have additional research that we're working on. But let's look at the next slide for a moment. So the work we did was with 2013 data. We actually had, at the time we started this, 2014 data, but that was a very tumultuous year for the Medicaid program, and there was the general belief that the 2013 data was more credible and reliable, and that our next modeling will jump over to looking at the 2015 data, which we're starting right now. We made a decision to build a concurrent risk score because, to the extent possible, we wanted to include in this risk score newborns, people who leave in mid-year. We also found that there were a fair number of people not generating a large fraction of the person months, but a fair number of people who really jumped in and out of the program, some even within a day or a month or 2 months, and we made a decision that our managed care payment system would only apply to people who were in the program for at least 6 months. That other ways of figuring out how to pay for care for people who were just transiently in the program would have to be used. And so basically, we also had the program divided into 2 parts. One of them is the so-called PCC, Primary Care Clinician Program, which is effectively a fee-for-service model with the claims actually linked to payments, and the other part being the managed care organization. And coming on board by the end of next year, we'll have accountable care organizations. But the data we had related separately to these 2 parts of the program. Next slide. Oops, next slide. Okay. So we talk about saying if something, if a risk factor is present, that adds money. But I think it's really important to back off for a moment and to understand what a risk score is and is not. Nothing that we do determines the total amount of money that the state is going to spend on the Medicaid population. We take that as a given, and that's why I've emphasized this relative risk score. What we're doing is moving money around within the program. So if we give a relative risk score of 1 and the mean payment for everybody in the state for a year of participation is $5,000, then we're saying the state will transfer $5,000. This is simplified, but basically that's what goes on. If we say that your relative risk score is 2, we're saying when you take on the care of this person, you'll get $10,000. You'll get 2 times that average cost. So when we talk about adding money, we're really talking about taking it away from somebody else who doesn't have any of these risk factors. We're talking about creating these relatives. I think that's probably all we need on this slide. Next. Okay, so as I said, we used concurrent modeling, and that just says that we used 1 year of data. We looked at all the risk factors that were present for that person during that 1 year. We related that to their costs during the same year. The model itself is actually used prospectively. We look at the data we have for a person in the past year, when they're enrolled next year, and we make a payment that's based on that. So it's a little confusing to a lot of people, but it makes sense, and we found that it works pretty well. That we actually, if we make these predictions that are concurrent, and we look at them for how well they predict next year, even at the person level, we have R-scores that are greater than 50%. We have, I'm sorry, I mistook that. We have R-scores that are in the high 20s, 20%, and they are at the top end of what anybody has been able to do in terms of predicting next year's costs using this year's data. So again, just a simple, quick technical point, we do annualized costs. So if a person's there for half a year, we double their spending and say they're spending at the rate of twice that amount of money per year, and we count them as half a person. Next slide. Okay, so this is a schematic of what the data look like. As you can see, there are actually more people in the MCO program than the PCC program, the PCC, again, being the indemnity program, and their characteristics are somewhat different. The very sickest people tend to have, in the past, aggregated within the PCC program, and part of the goal of this reimbursement strategy is to put enough money behind each person who is really sick so that the MCOs will feel, oh, that's an amount of money I can use to truly manage those people and give them good care. I think we can move on to the next slide. So technical detail, we used, we had to recognize that a new DXCG model was needed because to deal with ICD-10 as opposed to ICD-9 coding, and so we made that upgrade. As I said, we included sex-specific categories as predictors. We included the disability predictors. Next slide. The behavioral health predictors that I discussed before, and here's these two really bona fide social determinants of health variables that we were able to construct. The first one we used by looking at our administrative files and saying any person who during the last 12 months has recorded at least 3 distinct addresses or 2 changes of address during the 12 months, that person will be said to have unstable housing. We'll put that in the model. We'll see what it does. And it turns out to actually be, on top of all the other things in the model, it actually appears to carry a fair amount of weight. I'll show you that in a moment. We also tried to figure out how are we going to get a hold of who these homeless people are, because the putative variable for it that we had just doesn't work. And so in the short run, what we did is we said, if we find an ICD code, which we very rarely find in the data for homelessness, we will call that homeless, and we will by fiat give the same amount of money for a person who has this code as we give to a person who has unstable housing. Why? Because we found that if we actually put it into the model, it carried way too much weight. It carried something like $13,000 extra money. And we knew that that was because the only people who happened to get the ICD code in the current situation were very sick. They were in the hospital. They were running up big bills. People were frantic to try to figure out how to get them out. And we just knew that that wasn't right. So we said a first step we don't know how to price homelessness, but we will just say it certainly can't be any less serious than housing unstable, and so we'll give it the same coefficient. The neighborhood stress score was based on the fact that we do know where everybody lives pretty much in a geocodable way, and so we're able to put everybody in a census block group. There's about 5% that we can't. If they happen to be getting our homeless bonus, we're not changing the payment based on where they live, except for by giving the homeless bonus. And basically, we looked at a bunch of candidate variables that indicate social stress from the census, and we use that. Let's look at that in more detail. Next slide. So our neighborhood stress score, I'm not sure that this is the score that I want the whole world to use. We're actually going to rethink it a little bit in our version 1.1 that'll be coming up in a few months. But this worked pretty well. And we have 7 variables that you can pick up from the census, and each of those variables we coded it for each neighborhood in terms of standard deviation size steps away from average. We added them up and re-standardized it so that one increment in NSS, the neighborhood stress score, represent a 1 standard deviation increase in the economic stress of the neighborhood in which you live. Next slide. Okay, so here's what the model looks like in a mock-up in which we envision that the state is paying on average $5,000 per person, and we're saying on the leftmost column, we're looking at how common within the current MCO program these risk factors are, and what is the model coefficient. So let me help you read this. If we look at NSS 7 per SD unit, you see 0.01. So that's 1% of $5,000. So there's an extra $50 for each person that you're caring for who lives in a neighborhood that is 1 standard deviation worse than average, and an extra $100 for a person that lives in a neighborhood that's 2 standard deviations worse than average. And so a lot of people say, oh, well, that's not much money. But actually, if you think of having 2,000 people in your patient panel that you're caring for, and each one of them you're getting an extra $50, then you've got $100,000, which is real money to actually do something to address those extra problems. Because we have these other risk factors involved, the DXCG relative risk score itself, each unit doesn't count $5,000 the way that it would in a model which just said we're going to pay on multiples of the DXCG score. It's been reduced to about $3,300 per extra unit of DXCG score. Notice that there's a lot of money associated with clients of the Department of Mental Health, but there are very few such people currently in the managed care organization. One of the goals of this whole process is to make MCOs feel comfortable that they will have the money to deal with more difficult people. In this particular context of today's webinar, the homelessness by ICD-9 code and the 3+ addresses per year, that contributes, this is a really impressive amount of money, 11% increase in payments associated with being coded for unstable housing. And people who are advocates for the homeless people say, but well, that's only $550 and homeless people cost more than that. But notice that in the far right column that due to their many medical problems and other things, we paid almost $29,000, almost 6 times as much as average for a typical homeless person based on all of the information we have about them, including whether they're a client of the Department of Mental Health, et cetera. so that's a complicated slide. I know you can get the slides to look at later. I think we should go to the next one. As I said, we did not include, we did a whole bunch of modeling with long-term support services, and the problem is that you don't want to put into a model used long-term support services as a predictor of how much it costs. It's a terrible payment model. We do have some ideas for the people who are persistent users of long-term support services, which we define as using at least $500 worth of such services for at least 3 consecutive months during the prior year. They're just really expensive. And for the time being, we're going to have to try to deal with that outside of the capitated payment system. But we think that we may be able to use some technical ideas to create our next version in which we will actually be able to roll those costs in and make a payment that matches the need. Next. Okay, so this work, this first phase of it is available on the web, and the Massachusetts Innovations website, which is directly here, has in its previous meetings. We had a meeting in October. There's a slide deck presentation, not too different from this one, and there's also some substantial more detail about what we did and why. I think that's it. Next. Right. Thank you.
Thank you, Arlene. That was great. So I want to remind folks on the line that if you have a question, if you could type it into the chat feature, we'll be able to read it to Sarah and Arlene. I want to start with a question for both of you. For states interested in collecting and using SDOH information at the patient or population level, what key factors do you think they should consider as they move forward with this work? Sarah, can we start with you?
Sure. I think that the key factors are really what we've learned is that it's more than just the data collection and thinking about the broader context of the work. So whether that's some of the ethical considerations or whether that's some of the resources that exist to support this work, we might be able to address the technical challenges, but we want to make sure that we're moving in conjunction with the broader context.
From the point of view of people I'm working with in Massachusetts, there's a combination of trying to figure out for the future how we can sort of do the kind of thing that Oregon's doing, which is saying what are some things that we really want to have in the model and how are we going to get to being able to put them in the model. But there's also an opportunistic element, which is to say, how cleverly can we squeeze information out of the data sources that we already have in the short run so that we don't have to do nothing while we're waiting till we're in this future state where we have these other important variables well established.
Thanks to both of you. There's a question that came through the chat feature, and it's, are there any national organizations leading the way on creating standardized approach to SDOH measures collection? The National Association of Community Health Centers is piloting a tool called Prepare, P-R-A-P-A-R-E. It's available on their website. There's also the Health Leads Screening Toolkit, which includes SDOH measures. And also the IOM a couple of years ago released 12 SDOH measures that they recommended for inclusion in EHRs. So that's a starting point at the national level. So again, for Sarah and Arlene, just in terms of challenges you've encountered in your respective states in advancing the use of SDOH data, Sarah, what have been the most challenging aspects to developing this food security measure? And do you have any thoughts or observations for other states on how to make the selection and review process easier?
I think one of the biggest challenges we've had is essentially buy-in from the broader community, from our health plans and providers. And so some of the ways that we've been working on that is a lot of education. I think there's some knee-jerk reaction that can happen about, this isn't my responsibility. There's another agency that should be dealing with this. Why are you trying to take up more of my valuable primary care visit time? Which, you know, there are legitimate factors behind that. So I think we focused a lot on education. So again, that connection between health and some of the social determinants, and how addressing social determinants can help better manage the health conditions that are more traditionally the responsibility of the system. I'd also say having champions for this, having advocates and champions who can help with both the education and also those that have taken this on voluntarily. So I mentioned a couple of our health plans and providers that are doing some of this work. They had already been doing some of this before we even started talking about a measure, and so bringing those folks to the table and having them help carry the message forward can really help with developing that buy-in, but also they have a lot more expertise. I didn't know very much at all about food insecurity before we started this work, and it's been a learning experience for me, and there are a lot of other people that we've partnered with and that have helped educate us as staff, as well as helping bring everybody along.
So I don't have a lot to add. I think this buy-in, trust, really talking to the people that you're going to be asking to collect these data, it's very clear that clinicians are delighted to ask about social determinants of health, for which they have a very simple way to hand off the problem and know that it's going to be taken care of. And absent that, they're very, very resistant to doing that. I think it's very clear that Massachusetts is at a tipping point. The majority of people we speak to who are data owners or data seekers are enthusiastic about trying to create an information backbone across the state where such information could be collected once instead of by 5 separate agencies. And when you sit down and look up the person to try to help them with the problem that's in front of you, you could actually, you know, read down what's known about this whole array of different issues for them, put it in front of the person and say, you know, does this capture your actual needs? And so the data would be used and it would get better. There's enthusiasm for it. It's a big deal, though. It's a lot of work.
Okay, thanks to both of you. There are a couple of questions that have come through about other state activity around SDOH collection, and a question about the specific tools that I just mentioned. I would refer folks to the brief, the companion piece of this webinar that's available on our website, and there's more information on both states and those tools available there. Sarah, there's a question for you. Can you say more about how you are working to integrate your measures into the EHR? This tends to be a heavy lift, so any information you can share on that would be helpful.
Yeah, this absolutely is a heavy lift. And fortunately, food insecurity or social determinants of health was not the first place we started with this. We have several other measures in our pay-for-performance program that did require working to get the data out of EHR. So some were traditional, more standardized, meaningful use measures that theoretically exist in certified EHRs and can be generated. What we found in reality is that that's not always true, and just because it's a certified EHR and the measure is standardized doesn't mean that the reporting capacity is there. But we also have gone through this with implementing a depression screening measure out of the EHR. So yes, it's a heavy lift. I think there's a lot of custom work that has to happen, and our health plans have played a really strong role in working with their providers to help them build those reports. So we have one of our health plans where the health plan actually hosts the EHR for their whole provider network, and so they are able to do a lot of the builds sort of in-house. We've also looked at if there are opportunities to leverage with some of the EHR vendors. So we have some large some vendors who have large market share, and looking at ways where we could work with them directly. Do they understand the measure? Do they have all the details? Can we have a more efficient conversation so that each individual provider doesn't have to go to that vendor to ask? So we've been looking at that, but it's absolutely still a challenge.
Yeah, I think that one of the very nice things about the Prepare toolkit and initiative is that they've thought from the get-go about how to work with the major EHR providers to incorporate this into their into their systems. So if you did, you know, if it were decided that Prepare was the tool to go with, and there are, you know, it has a lot going for it, and in particular, the fact that they started by thinking through how it would integrate with EHRs.
Although I would add, one thing that we've experienced is that there can be a difference if it's designed for the EHR, for the provider and the clinic use. That may not necessarily translate to it being designed for a report that then can be aggregated at the health plan level or the state level and used for other purposes outside of the practice.
True.
All right, thanks to you both. Arlene, a question about the neighborhood stress score. When compiling data on neighborhood stressors, did you consider including violence in the home and crime in the neighborhood?
So the short answer is we didn't this round. We are actually in active discussions with the Department of Public Health to look at those many social determinants of health variables that they have and try to figure out which ones might be considered for inclusion in the next round.
Okay, thanks. And another one for you. Will Mass Health provide social risk info to the MCOs and ACOs so they can use it to support patients?
So Mass Health is at this point providing all the information that goes into its risk score to the ACOs and MCOs. So I guess the short answer is yes, but it's limited. I mean, you know, we're very excited to have taken this step to actually incorporate some of this stuff into our models, but it's fairly thin still. We don't have a lot of social determinants of health information to report back.
Okay, thanks, Arlene. And to both of you, we realize that both Oregon and Massachusetts are early on in the specific initiatives that were discussed on the webinar, but I wonder if you could both talk a little bit about what you think the successes of your SDOH measurements are to date, and if there are any evaluation plans sort of associated with these efforts.
I can start. I think what I would list as our success is essentially changing the conversation. When we first started with our incentive measure program, the conversation was very, again, traditional HEDIS measures, very process-focused. And the fact that we've been spending, a year or more having these conversations about how do we actually measure social determinants of health and how do we work through all of these challenges and the technical details. And not everybody agrees, absolutely. Not everybody is bought into this, but I think we've moved the conversation significantly, and it's something we're looking at incorporating in other projects, not just the incentive measure program, and I think that's been essentially some of that sea change that's really driving the work now.
So I would say that we have a similar experience in the sense that we've gotten virtually universal praise for taking this on and for doing as much as we have. People were very interested in hearing about what we had done, have asked lots of questions, but we haven't had any pushback. We haven't had anybody say, well, that's a terrible variable to put in. I don't want to be paid with a model that has that in. So I do think we have that positive environment. What we've learned is that you can't just pay more money to an organization that doesn't know how to care for a kind of social or medical complexity that it doesn't usually care for. And so putting enough money in there to presumably enable organizations to care for these complex, vulnerable people is only one step in a larger exercise of actually working with the stakeholders, and the state has actually done a pretty amazing job of holding very broad-based stakeholder meetings in which they've heard the concerns of the community of people who really need those home health aides and who need those extra social services about what those people want the state to do to ensure that they will get them, and not just to have a formula which happens to pay more money in case you have such a person.
Okay, thanks. And I think this is our final question for the webinar in case something else pops up. But how are, in both your states, how are you addressing the fact that collecting SDOH information is just one more thing for providers to do? In what ways are Oregon and Massachusetts supporting providers in this collection effort?
So maybe I'll start since Sarah's taken the lead before. And the truth is we're just trying very, very hard to get this information without further burdening providers. On the other hand, we and most of the people we're talking with kind of believe that to the extent that the state can actually, to the extent that resources can be found that help with these problems, that it's a win-win for everybody. And so, the big problem, I think, is this concern that people have that will surface problems for which there's, no current action. I hear that this terrible thing is going on in your life, Mrs. Smith. Now let's move on to the next problem. And so there has to be this putting together of the resources to address the problems at the same time as you try to build it into the system.
I absolutely agree with that. I think there's a lot, again, going back to that education and thinking about the return on investment. But one of the approaches that we've taken when we've been talking about this work with providers or thinking about implementation at the provider level is that it's not just the provider, when we say the primary care provider, the doc themselves. We've been really focused in some other initiatives in Oregon on our medical home model and team-based integrated care. And so thinking about workflows that rely on other staff that are in the office and that can provide other resources. So again, the example I provided earlier about the community navigator who's essentially embedded in a site and helps make those connections. So maybe it's the medical assistant who does the screening. The information is in the EHR for the PCP to see if it affects any health conditions or management that might be affecting on the medical side, but then the rest of the care team is helping with those connections and coordination. So I think that we have a tendency to assume that it's the provider responsibility, but there is the broader care team, and we also try to think about other ways that workflow could roll out.
Thanks very much, Sarah. I want to thank both Arlene and Sarah for their participation today. This is just a great webinar. Just information on chcs.org for those of you who are interested in reading the brief. It's available online. And thanks to everyone for joining today. We really appreciate your time.
Thank you. Bye-bye.
Oh, folks, just before you hang up, there's a survey. If you could just take a couple minutes and fill that out, we'd be most appreciative. Thank you.
Ladies and gentlemen, that does conclude today's presentation. Thank you for your participation. You may now disconnect.